Okay, well, this is the last talk, and I stayed through it all as well, so I bear your pain, and I don't want to intensify it. Basically, I had the opportunity to talk to you really because we're trying to start something, and so we're working together between research and education. And so what I'm looking to help with is to find going from the bedside to basic science. So I'm a clinician. I've been here since 1981, so I think I won that award. Basically what I found that's most helpful to me was the individual case and getting it down to the genetic and molecular level. And so what I'd like to do is to share that with some people to be involved in that enterprise. So what we're looking for is a unique, difficult case for which no consensus report or algorithm exists. In other words, we don't know what to do, okay? And so what we have to do is really go to the literature. What I want to have is a scientific team approach to medical care. And so it brings basic science into the clinical practice. And it's also going to be preparation for precision medicine and the goal of being a physician scientist. In other words, you spend your first 2 years in science, and then there's medicine. And what's going on today is we're doing a little bit more of being a physician data entry, okay? And that's going to be replaced by nurse practitioners and by AI, artificial intelligence. So we want to help you to form a differentiating factor. Potentially, this could benefit the students, residents, fellows, staff, institution, and patient. The team, what I'd like to do is to think of making a whole team. And so this would be the Queensland Oshner student. The endocrine fellow I have starred, because if we have the fellow, then that can continue the care and the other options. We would, the resident is optional, that's hard to do here. A staff physician of the patient so that we have that clinical connection. An Oshner expert, scientists, whether internal or external, and supported by the research of Dr. Alan and Dr. Ray. Dr. Ray is the image of a physician scientist, okay, and he'll take you down to molecular biology. And is supported in education by Leo here. So what's the process? So what I do on EPIC is I keep a list of what I call Remind Me, of all the patients that I found were really interesting, but I didn't have the time to take care of, okay? So I have that list, and I hope other people will make that list. And then what we want to do is review the case, pertinent history, physical findings, laboratory, and appropriate review of the x-rays with radiology and the tissue with the pathologist. In other words, you should go down and go over those things and really get it in depth. Background, basic science related to the case, form a hypothesis, do further testing, and then eventually what we would want to do is have a short phenotypic and genetic description, because as I said, this could go into the precision medicine of the future. In addition, presentation to Queensland peers and team, and hopefully a publication with an abstract or a more detailed publication. So that's what the idea is, but the team would help you to get through all of that. So what I would just tell you is, as a doc, what really improved my clinical skills, I'm a bone kind of a guy in osteoporosis, is when I had a family here of osteogenesis imperfecta, and we found about 250 members of the family back to Mariasma, Oakland, when she came to this area from Nova Scotia. That taught me about how to take care of patients with osteoporosis. Then I had a patient who was sent to me because her bone density was high. Well, we figured out her gene mutation, which was an LRP5 mutation, and that led us to the Wnt pathway, and that's crucial for all sorts of things in bone and making bone, but it's crucial for cancers, etc. And then I have a lady with tumoral calcinosis. We identified her gene, and so she has a defect in Galin-3, but I learned about phosphorus and vascular calcification not coming from cholesterol, but coming because of high phosphorus. So now the thing I want to do is give you my proof of concept. And I had a patient who we saw on rounds, and the fellow picked it up right away, hypercalcemia and liver cirrhosis. What's the connection there? So we've seen a couple of them, and we now were able to pick up 5 cases but maybe we need to go back to Epic with the slicer dicer and find out how many other cases that we have here. And then we think that there may be multiple factorial things going on here, including immobilization, cholestasis, etc. But there was an article published by Nashbandi called Oglycosylation of fibronectin mediates hepatic osteodystrophy. And what it is fibronectin you may have had in your training, you have heard about, but it's really all over the place. And it's the matrix switch. So just like Lily was talking about the fact that the stromal cells are so important in cancer, well, fibronectin is a key player. And in fact, I'm getting to be a fibronectin kind of guy right now. You know, I can pass through these phases, but it looks like oncofetal fibronectin, when you have it in the fetus, it's also made by tumors, but it's made by wound healing, and it's made by cirrhosis. So what's cirrhosis? Wound healing cancer, I don't know. But basically what you're doing is making lots of collagen. So what we did is we started reading about fibronectin like I just told you about. And then what we did was we said, okay, we've read that lady's article, and so what we decided to do was call her. So we called Dr. Nashbandi, who's a lovely person, great doc, who's published really tremendously on this, and she said that she would like to play. So what we would like to do is find out if the hypercalcemia is caused, okay, by the fact that fibronectin, or in this case, oncofetal fibronectin, made in the liver, can circulate and can shut off bone formation, okay, in the bone marrow and in the bone. So that's what our long-term hypothesis is. But then I thought to myself, hold it, I'm taking care of liver patients. I'm in the #1 place for liver transplants in the whole world. So I said to her, you know, I'm looking at your work, but what cell makes the oncofetal fibronectin, and what cell makes the fibronectin? No proof of that we could find in the literature. So I went and talked to Dr. Ari Cohen, and he said that he would be happy to work, and then Gretchen Galliano pathology. And so what we're going to do is send Dr. Nashbandi the specimens of normal tissue, and then a bunch of different kinds of cirrhosis, and then see if we can identify whether it's coming. We think it's going to be coming from the stellate cells, okay? The oncofetal fibronectin and the radial fibronectin from the hepatocyte. But that's our proof of concept. So what I would just say to you, from my point of view, is seeing one patient led me to basic science, okay? And so what I want you to do is to use your basic science that you've spent 2 years doing, mastery, and then when it comes time when we have the human genome in our hand, you're going to be a better doc at helping that patient and being in a wonderful position. So that's what our goal is. And so if you identify an interesting patient, or if you're going into a field and you talk to the people and it's one that they haven't been able to do the genetics for, then we will try and be of assistance to you to do that. I can't do everybody. I can only take a couple patients, but we'll start out with a small group, and then if it looks like it's working, then we'll extend that. So with that, I hope everybody has a great day. Anybody have any questions? Okay, thanks.
Nice to know.